Wonderful to be here today. Where's the advance on this little guy here?
Yeah, you go with this.
Okay.
Yeah.
Yeah. So my disclosures are that the work that's presented here, that would be my work, has been supported by the National Cancer Institute. And I'll be talking a little bit about off-label use of drugs that have been through the history of chemo prevention. Now, if we were to go to look first, and this is a little bit of a kind of way to think about this differently. I do a fair amount of peer review for the NCI, so I get to review breast cancer and colon cancer and other kind of malignancies outside of oral cavity cancer. And sometimes I try to think about where we might be lagging a little bit compared to some of the other malignancies. So if we were to look at the pre-HPV survival rate of cancers, and I like to compare our malignancy, oral cavity cancer at the bottom, it has a blue circle around it, with the deaths per 100,000 per year for other cancers. So at the top, we have female breast in red. We have colon and rectal cancer, both sexes in green. And this was pulled out of SEER data in the pre-HPV era until about 2005. And if you look at the slope of the lines, there's been a lot fewer deaths from colon and breast cancer over the years, and the slope of that line has decreased quite a bit since I was in medical training in the early 90s. Now, if we look at oral cavity carcinoma, the slope is not nearly as acute as what we see. So we're not making as much progress in malignancies that are perhaps a little bit more screened than what we're used to doing, or also might have a chemo prevention. So if we use breast as a model and we look at the inner circle, we see that we have the core things that we as head and neck surgeons will apply. We'll apply surgery, we'll apply radiation therapy, sometimes there's chemoradiotherapy. In breast cancer, there's multiple lines of chemotherapy, but they also have a lot of other things that fit in to what Dr. Day even talked about, where you look at screening, prevention, advocacy, and education of the patient population. You have Susan Komen, things like that for the breast cancer population. And you have all this stuff, but if you look at what we have for ourselves, we do have, we have one line of chemo, but outside of that inner circle of the acute treatment of malignancy, we really don't have the similar kind of screening like you have with mammography or MRI imaging or any of these other things. We don't have tamoxifen. We haven't traditionally had the same level of advocacy and education that you've seen over the course of that graph from basically the mid-'80s till now. So we're talking about 30 years. So I think that all of these areas are ripe in a way for us to make a difference in head and neck cancer management and improve survival. If you look at things that are attractive about chemo prevention, as a general rule, preventing cancer is going to be a public health good. We'd like to manage that. We'd like to get fewer people to smoke and all this sort of thing. We feel that, oftentimes in my world of chemo prevention, it could be one component of a multidisciplinary clinic if there was really effective screening, surveillance, and prevention of the individuals. It might result in stage migration of the disease. So what I mean by that is as soon as we get a neck metastases from an oral cavity carcinoma, we lose about 20 survival points. And if you look at the concept that if there is increased public awareness, if there is potential for prevention, if there is more surveillance and screening and all that, that we might be able to get stage 3 disease, stage 4 disease to work its way up to stage 1 and stage 2 disease. So that's one of these things that I felt for a long time. Clearly, it's happened in breast and colon cancer, breast cancer for sure. If you look at late diagnosis of breast cancer, you almost don't even see it these days. So stage migration in and of itself, through prevention and screening type clinics in a multifactorial effort, would probably give us an extra 10 or 20 survival points in our malignancies. The lesions for prevention targeting, which is very attractive to me as a scientist, they're probably less mutated than large tumors and metastases. So if you look, they're going to have that loss of heterozygosity that was talked about 20 years ago, but they're probably not going to have all of the redundant kinase signaling and the types of things that you see once you get onto metastatic disease, which should be a heck of a lot more difficult to target than earlier lesions. Now, there's unattractive features to this as well. It's, prevention and screening and looking at like implantus patients and knowing what proliferative verrucous leukoplakia is. All these types of things are not a feature of why we became head and neck cancer surgeons. That's one of the things, it's not why we did that, but they're sort of our patients too. So we need to think about the whole thing a little bit differently, I believe. we've had a history of largely ineffective clinical trials when they move to the phase 3 level. And I'll come up with an example of that in a couple of slides. There's a very big difficulty in that the dental and medical communities are not melded by common platforms. When I've done some work in looking at state survival of oral cavity malignancy, through STEER statistics, Minnesota does a little bit better than a lot of the states, but we've had a fellow named Nelson Rodas, who's my partner at the dental school, who's been training dentists to do oral cavity carcinoma examinations for like 30 years now. I'm paired up with him. I'm also faculty at the dental school. There's not a medical record that melds these things. We've looked at some of these comparative effectiveness grants that were the Obama stimulus grants, and we put a couple in to use oral cavity cancer as a platform to try and meld dental and medical thinking about how to examine things, and even to look at how the records come. Because how often in a medical office we could get an electronic medical record from our chemotherapists and our radiation oncologists, but I cannot get a medical record from our dental school that's electronic because it's in a different system. It's not in the same insurance system oftentimes too. So these are all difficult things that we have to face. The other thing that comes up that's kind of unattractive is what should we target? Should we target leukoplakia lesions that have been historically done? Should we target high-risk loss of heterozygosity, which really implies that you have a good scientific infrastructure to be able to make those analyses? Should we target second primary lesions in a secondary prevention sense? So those are unattractive things that really can be confusing for us as practitioners. A couple of definitions that might be useful. If you look at what primary prevention is, that would be avoidance of alcohol or tobacco, so that's prevention. If you look at primary chemoprevention, we're talking about trying to reverse a lesion or a condition, whether that's leukoplakia, angiogenesis, high-risk loss of heterozygosity, cyclin D1. You could pick something and just say that that's going to be your endpoint for a clinical trial. When you look at secondary chemoprevention, we're really talking about trying to prevent second primaries from people or recurrences in people who've already been afflicted with the malignancy. So those are definitions that I think as head and neck surgeons it's worth for us to be familiar with. Now, I'll spend a little bit of extra time on this slide, even though it's only a couple bullet points, because this is sort of the types of strategies that have been used over the past 35 years to go about the chemoprevention clinical trials and things of this nature. So if we look, the one that has been in use for the most period of time that was championed by Wan Ki Hong were the forced differentiation strategies. So these involved the original features that cis-retinoic acid could be used to mature squamous mucosa, and that's a good way to go. And then for all of the 80s and a lot of the 90s, that was the original strategy that was proposed by MD Anderson, and there was a lot of mileage from those types of strategies, and biomarkers and everything else were found. I use thiazolidinediones, which are diabetes drugs, and that's what I've used in clinical trials, and that's a little bit of a takeoff on this forced differentiation strategy. There have been anti-inflammatory drugs that have used. A lot of the concept there is that about 15% of the world's malignancies are inflammation associated. If you look at any of the lesions, pick any leukoplakia lesion, they're going to have varying degrees of inflammation within those lesions themselves. So there have been things like Celecoxib, Sulindac that have been used. Ketorolac is another nonsteroidal that's been used. An attractive strategy is to use anti-EGF receptor type strategies. Tarceva and Cetuximab have both been used in clinical trials. And it's very attractive because, again, this goes back to the idea that you have this overexpression of the EGF receptor, and it's probably a lesion that's going to be less mutated than the people with recurrent head and neck cancer who are getting Cetuximab IV after they had their second go-around for treatment. Dietary compounds are also very attractive. The ones that have been used or are being used or have been even proven to be successful, there's work out of Ohio State where they use raspberry extracts and different kinds of berry-type extracts. Curcumin has been used in a couple of clinical trials, and I know that there's one that I think has just completed in India. The results aren't out yet. There's a large trial that's between the head and neck cancer spore grants that is looking at the use of soy isoflavones in a phase 3 sense. The Bowman Birk inhibitor is work that has been over the last 10 years, and it was shown not to be effective in a large randomized trial last year, but it was an idea that you would use these protease inhibitors to try and prevent malignant conversion. And there's been T polyphenols, Tocopherals, vitamin E compounds, things of this nature. The idea of restoring P53 is attractive. There was one study that was done with Adenovirus Onyx 015. It was a successful trial, but the company decided to go ahead and do more targeting in lungs. So that was a very interesting mouthwash trial that was done about 15 years ago. And then there's ablative techniques, which would be excision, photodynamic therapy, things of this nature. And there's different things that are attractive about all these. The concept of forcing cells to be mature is great. The idea of getting rid of inflammation is great. With ablation techniques, you might get rid of all the cancer stem cells as well. Restoring P53 would target the principal thing that seems to be responsible for progression of oral cavity malignancies. So those are basically all of the strategies that have been used over the last 25 years or so. The other concept would be is that you can go ahead and you might want to try alternative delivery strategies for some of these agents as well. So we're all used to taking pills, but pills can have systemic toxicity. There have been, with nanoparticle technology, with all the types of delivery techniques that are out there, if they could put nanoparticles in chewing gum and these little polylactic acid things that we eat from the Dentine company, you should certainly be able to go ahead and think about putting any of these drugs in mouthwash or gum. It might be very attractive because a lot of us will already use steroid topical delivery for inflammatory conditions of the oral cavity. Everyone knows how to use kenalog orabase and things like that, so that's attractive as well. Using photodynamic therapy and laser and light targeting strategies to ablate things, nanoparticles and aerosols as well. And one thing that's sort of interesting is that if you look at field of carcinogenesis, with some of these techniques, either systemic delivery or regional delivery, you can actually go ahead and target field carcinogenesis. So you might not just be preventing oral cavity cancer, but you might also be going after other lesions that could become malignant in people with field carcinogenesis. Now, if we go ahead and use just the retinoid chemoprevention and nuclear receptors as sort of a case example of how a lot of this has worked and where at times we've failed. If one looks through the 1980s, there were outstanding clinical trials published in New England Journal, multidisciplinary, multi-center, multidisciplinary trials, and the 13-cis-retinoic acid higher dose clinical trials were effective. They identified biomarkers. They did a heck of a lot to advance the whole field of chemoprevention. But when those trials were brought into national phase 3 trials, a lot of things happened. One thing that happened is that you had to come down to cis-retinoic acid that was less toxic. So you had to lose maybe threefold of the dosing that you might want to give to people because of toxicity. And at the end of the day, by ratcheting down the concentration of cis-retinoic acid in the bloodstream, these lesions, these trials were not effective, and they weren't effective. And they started out in primary chemoprevention setting. They went on to secondary chemoprevention setting, and they didn't pan out. Now the concept is people still feel that retinoids are useful, or drugs that are similar to those are good for chemoprevention. And retinoic acid is used as a neuroblastoma treatment in kids, but it's given as a chemotherapy drug with a lot of side effects. If you look at what's happening now, there's been advances in redesign of retinoids to try and come up with less toxic retinoids. It's an initiative that's been supported by the NCI for a long time. Where we've gone after things is we look at targeting things with PPAR gamma activators, one of the thiazolidinedione class of drugs, and I'll go through just a little bit of how we've gone with that, and I'll present one of our clinical trials. So there have been both pioglitazone and rosiglitazone clinical trials that have been performed, and the idea would be a forced differentiation idea where you're allowing the pioglitazone drug to interact with the retinoid receptor, and then once those two have binding, they'll set off a lot of events that would be associated with terminal differentiation, decreased inflammation, a lot of things. It's a pleiotropic kind of an effect. And we target the leukoplakia lesion, which affects about 1% of the adult population. It's felt to be an acceptable surrogate for head and neck cancer prevention clinical trials. It has between a 1 and 30% conversion risk to cancer over 5 years, depending on whose literature you read and where the location is and how much dysplasia there is in these lesions. And there was a strong rationale for this work that's been supported by the NCI. With these ligands were used in prevention studies, and in animal models. And there was a very interesting epidemiologic study that showed up to a 50 to 60% decrease in head and neck carcinoma in patients who were on these thiazolidinedione drugs for about 18 months or so. And this was a VA epidemiologic study that was done through the VISN database, 130,000 patients. So there was a reasonably strong rationale to go ahead with this for clinical trials. We ran one clinical trial. This trial is very mature at this point in time, but I don't think it's really been presented at a head and neck meeting before. Some of the prevention meetings it's been presented. But what we did is it was a phase 2 open label trial. It was NCI Department of Chemoprevention contract. Patients were screened if they had dysplasia of high-risk sites. They were treated for 12 weeks with thiazolidinedione drug called Actos, which is pioglitazone. They were rebiopsied at about 12 weeks later. And there were biomarkers that were collected at the same time. And what we had found out is that when we looked at our responses, we had about a 71% response rate in that open label clinical trial, which was enough of a signal for us to go a little bit forward with this work, and that was also supported by the NCI. And the kind of things that we were seeing is we were seeing that the lesions would really resolve themselves in about 12 weeks. The histology was not really resolving itself in just 12 weeks. But we'd see where we'd have a person with a leukoplakia, and that thing would, and after biopsy would be on the left, and then after treatment, but before biopsy would be on the right. And this prompted the NCI to support a phase 2B clinical trial through a relatively arduous mechanism. It took about 3 years just to get the trial up and running. It's a barrier to try and go ahead and get some of these things going, but it was co-opted through the NCI. And it involved University of Alabama, University of Iowa, Brigham and Women's. It involved about 10 or 12 different centers. Clinicaltrials.gov would give all the details of this. And this was an ongoing trial for about 3.5 years. And we accrued the cohort. We didn't meet full accrual, but we accrued them by about February of last year. Treatment ended this spring, and we're waiting the database lock and then the blind breaking to see what the results of this are in a randomized clinical trial. So if we look at some of the challenges that we have, to go back to some of the things at the beginning, is I feel that there's a need to engage and create these multidisciplinary platforms between the dental and medical communities. I think that that's absolutely integral to making these surveillance programs and prevention programs working, because we do need to get better survival out of our patients than what we've been able to do with all the fantastic imaging and free flaps and everything else. We feel that if both the medical and dental communities are able to work a little bit closer together, there could be cross referrals to things like autofluorescence diagnostic trials or other types of imaging technologies. But we feel that that's an important thing. We feel that also that there needs to be a little bit more scientific examination of some of these molecular pathways. So I know Silvio Gutkan gave a great talk this morning, but to really examine the molecular carcinogenesis of head and neck cancer at an earlier stage is very, very important. The issue is that people have tumor banks, but it's not that common for a cancer center that's funded by the NCI to keep a preneoplastic disease tumor bank. It's something that just doesn't exist. They're expensive to keep these things up, and to get good molecular analyses out of these things is pretty expensive, but I think that they're a valuable asset. The concept of doing proteomics, genomics, and sequencing on these preneoplastic lesions might be a very good thing to do in the near future, now that the Cancer Big Project at NCI has worked quite extensively on invasive disease. There's some interest in going after the preneoplastic diseases as well. Get further insight on this, and that's all. One last slide is that there's other challenges that we have, and an issue that we run across is that you're not going to really be able to get a pharmaceutical company to have a drug that's being used for one thing. I like doing reuse strategies, using FDA-approved products that I could bring into the leukoplakia realm based on other things that these drugs do. But pharma needs to come on board, but it's difficult to get them engaged. And there's a lot of natural products and their derivatives that can be used, and that can be often a lot easier than trying to use pharmaceutical compounds, especially if you have to develop them yourselves. So thank you.